Hey, this is QD Clinic, brought to you by Room Now Live, where we're changing minds in practice one practitioner at a time. So our case today is change or not. We talked about this patient under optimizing methotrexate, and the patient is a 56-year-old with rheumatoid arthritis since 2006, managed for the last 12 years with methotrexate and etanercept and doing really well, in remission most of that time. However, in the last few visits, she comes in with a more nuisance complaints. Her pain is at 2. Her CDI score is an 8 at this visit. She has 6 tender joints and 1 swollen joint, an MCP, and she says she's having problems with her hand on the right side. And she thinks it's from walking the dog, and she's got some kind of excuse for it, but it could be just her rheumatoid arthritis not under great control. So in the last video, we talked about maybe you should optimize methotrexate. Let's talk about, let's say she doesn't, you can't optimize methotrexate, you're maxed out on methotrexate. Now it's a matter of sticking with what you've got, or adding on another DMARD, or adding on prednisone, or changing biologics. So in this particular case, I think you should recognize that most patients don't want to change. And there's really several good reasons for this. They're very fearful of what they don't know. Fred Wolf's got a great paper in J Room from about 10, 15 years ago, looked at why patients change. This is looking at the National Data Bank, why patients change. And the top reason why patients won't change is they're very fearful of what may happen with a new therapy. Even when you tell them there's a guaranteed improvement to be expected, they're likely to accept low levels or manageable levels of discomfort, inconvenience, and whatnot, as opposed to changing to something new, cool, wonderful. You know, there's all kinds of risks for them. They might be financial risks, there are side effect risks. They're very fearful of that. And so you actually have to be, a very good salesman to explain why this change might be warranted in this particular patient. Here, are we going to change for 1 swollen joint? Not at this one visit, but realize in the last 6 visits, more than half of her visits have not been in low disease activity or in remission, but have been in sort of low-level CDI scores between 8 and 15. So the issue is here, we could have the discussion on changing her etanercept to another biologic. She can't, let's say, increase her methotrexate for one reason or another. The other option is adding in prednisone, which she's taken before. Some patients will accept a low dose of prednisone, maybe even as little as 2.5 milligrams, to do very, very well without the added inconvenience and cost and worry of a new biologic. So that's a reasonable option. I'm personally not in favor of adding on another Plaquenil or sulfasalazine, but you could do that as well. That seems to work. You could convert her to triple DMARD therapy, and that would be cheaper and maybe even better for some patients. Patients prefer pills. So the first question is, should I change or not? And really, to make this decision, you really need to be a metrics-driven individual, which means that you need to do tender joint count, swollen joint count, and then some measure of a score. You need to do a rapid score, which is something the patient does by themselves, and you don't have to do a joint exam. I don't know why a rheumatologist would not do a joint exam on every patient at every visit. That escapes me. But if you want to save time and couldn't do a joint exam this time, you could get by with a rapid score. You can do the joint count, the swollen joint count, tender joint count, and calculate a CDI or an SDI score. I do a joint count, a pain score, a hack score. My score is called a GAS score, a global arthritis score. It's a 28 joint tender count, plus their pain score, plus their hack score. And actually it correlates almost incredibly well with a CDI score. So I rely on tender joint counts as opposed to swollen joint counts, because everybody can do a tender joint count. Only a world expert like me and you can do a swollen joint count. So it's very reproducible, but having the metric lets you see what the trends are, and you don't have to rely on what's happening here and now with this 1 or 2 swollen joints today, and the patient wants to live with it. So I think the idea here is you need to find out what they want and how they're willing to operate. So I think that in my patient, this is going to be her second biologic after taking etanercept. I think, ask her what's ideal. Does she want an injection, or does she only want to deal with pills? And I think in choosing your next biologic, you can go with the ideals, things that you recommend, something she's heard about, maybe her aunt was taking this, that sort of thing. And I think that, when they're motivated to take something, give them their option, you're going to increase the odds of improvement. However, if this is now going to be their third or fourth or subsequent biologic or DMARD combination, now patient choice becomes a little bit less of a consideration, and now you're tending to back into what you can reasonably do based on what the patient experienced before. So I call this defensive prescribing. So if they've had hepatitis before, you really can't do, give them certain drugs like methotrexate or Reva. Maybe even if they had LFT elevations with a JAK inhibitor, you probably shouldn't use Actemra in those people. Same thing for other things like infections, TB, chronic lung disease, recurrent infections, cancer. Those are things that tend to make you defensively prescribe, where you back into the one or two options that are safest for that patient, and you can sell that reasonably well, and the patient's willing to accept that. So I think having a threshold, I think that the data I want to impart upon you is there's very good data. It's as much as great, rheumatologists are great at managing RA and diseases like RA, and doing so without even having the metrics, there's pretty damning data about how many rheumatologists do not change therapy, DMARD therapy, in the face of active disease. This comes from large cohort studies, large longitudinal registries that are based in practices like Corona and whatnot, that show even when you measure, even when you declare the patient to be moderate or severely active, the number of patients that you, the rheumatologist, change is really shockingly low. Meaning that with 6 months or more of moderate disease, only a third are changing DMARDs. To get to a majority, you have to go out 1 year before over 63% of patients will in fact change their DMARD. And that means a conventional DMARD or a biologic DMARD change. That's pretty bad. In my book, we should be making these decisions about success or failure in therapy every 6 weeks. Unless you're talking about gold, penicillamine, and rituximab, you're going to know in 6 weeks whether or not you're hitting a home run with whatever new drug you've prescribed. Decisions need to be made definitively and based on hard facts. And you should push it, because left up to the patient, they may not want to change. So I think, again, getting patient buy-in, having the discussion are all important factors in making these hard decisions about whether to change or not. Tune in for more QD videos. Go to rheumnow.live to see what's going on. The faculty looks amazing.